So thank you, Danielle, and a very good afternoon to you all. My name is Paul Elbers. I'm from Amsterdam. I have to admit that I was actually taught ultrasound by Professor Lichtenstein. So I'm very grateful for that because it really changed my life. I don't really agree with everything he says, but he has a nice way of putting it, and he actually does use it in his patients, and so do I. So I would strongly encourage you to do so yourself, because you will find it to be magical. I specifically don't like all the acronyms that are being used in ultrasound, because every group tries to invent their own acronym, including the American College of Surgeons, because they came up with this FAST, the focused assessment by sonography in trauma, and they now have EFAST. I'll come back to that later. But I was just told during lunch by Professor Lichtenstein that he actually invented the FAST protocol, and that the surgeons, they stole it from him. Okay, so you have to remember that. So, but I like to teach the holistic approach, so I invented my own acronym, which is Intensive Care Ultrasound, so ICARUS, which is nice as a kind of a Greek touch, although you don't want to know what happened to Icarus, of course. But I think it's important to distinguish intensive care ultrasound from other forms of ultrasound, because you don't want to get any discussions with other disciplines doing ultrasound. You want to define it as a discipline for intensivists. So you, as an intensivist, are the only person that can actually correctly interpret these images. So having said that, we are going to try and make this clicker work. I recognize your problem, Daniel. So there are always many people trying to define what you should learn, and they use many words for that. So these are the competencies that you probably should have according to the International Anesthesia Research Society. But I think that's a bit too many words. So I have summarized this for you. I think you should learn fast. And if you have extra time, you can use abdominal ultrasound for other cool stuff, such as visualizing the great vessels, the gallbladder, and the kidneys. So we will first discuss the classic FAST protocol, which is actually really simple. And then we'll look at some more advanced stuff. And the idea is that I will probably not need the full half hour, so that will leave us more time to actually practice, because that's even better. So what do you do when you do abdominal ultrasound? So you want to look a bit deeper than superficial, of course, right? So you want to have a probe that has a frequency range to reach the full abdomen. So you can, of course, use the classic abdominal probe, but if you want to be fast, you can also use one intermediate probe or the cardial probe. And the marker should either be cranial, if you work in a cranial to caudal direction, or the marker should be right. Okay, of course, as an intensivist, you can place the marker anywhere you like, because the important thing is that you recognize the image, but these are the conventions. And the orientation point in the image should then be on the left. So, and that facilitates, of course, repetitive exams and also discussions with other disciplines. The FAST protocol is about looking for fluid. So it helps that you know the abdominal anatomy, so you know where the fluid is going to go, because it goes, of course, to the lowest point. So as pictured here, it's actually a very easy protocol, but the point to remember is that you should not move your patient about too much, because that will change where the fluid goes. So that also sounds very simple, and it is. So if you look at it in more detail, these are the places that you can expect fluid in. So here we have the hepatorenal recess, also called Morrison's pouch. And you have a similar pouch, the splenorenal recess. In some countries, this is also called Collar's pouch. And that is where fluid accumulates. So there's a little tricky thing with the spleen, but we'll come back to that later. Also, we of course have the rectovesical pouch, Douglas called in some countries. And and there can also be free fluid in the stomach itself, and in the ascites. So once again, you have to remember the patterns where these fluids usually go, so you can look for them quickly. Okay, so the FAST protocol uses 4 views, and the first view that has already been taught to you. It's the subcostal cardiac view. So we're looking for pericardial effusions there. The second and third one are looking for fluids in the Morrison and collar pouches, or the splenorenal recess and the hepatorenal recess. And the fourth position is looking for fluid in the rectovesical pouch. So if you want to take a systematic approach to that, it doesn't really matter where you begin, but it's usually, if you have a sick patient, it's probably useful to start with the subcostal cardiac view, because you also get the cardiac view as a bonus. You look for pericardial effusion, and of course tamponade remains a clinical diagnosis, but it can definitely rule out tamponade. Then you start looking for fluids in the right upper quadrant, or the left upper quadrant. Probably a good idea to make a cranial to caudal movement to scan the whole region. And as a bonus, you will also see pleural effusions there. So because I'll give you an example of that in a minute. And the pelvis, you will, as a bonus, you will also see if the bladder is filled or not. So this is an example of the first view, the subcostal cardiac view, and there's obvious pericardial effusion here. And this is the example of the pleural fluid that you really get as a gift when you're doing the FAST protocol. So once again, the subcostal view, you'll probably recognize the structures now, the right ventricle, left ventricle, and the atrial. And you have your pericardial effusion here. So you want to look for diastolic or systolic collapse of the atria and also of the ventricles to either rule in or rule out a diagnosis of tamponade. However, this is not a specific goal of the FAST protocol. You just want to look for fluid or not. Okay. What's this? Anybody? Okay, this is Morrison's pouch. So we have a liver and a kidney. And here's fluid. So this is a positive FAST. This is the same thing, but it's negative. So the idea is that we're going to practice on the volunteer, so you're unlikely to see a positive FAST. But the fluid should be in between here. But don't hesitate to look a bit further, because sometimes you may be surprised that the fluid can actually be here or even here. So you want to look a bit further than the FAST itself. Okay. Similar thing. I'll just show you some examples to make sure you recognize the interface between kidney and liver. So on the other side, we of course have the spleen. So we can visualize the splenorenal recess, so the collar pouch. The interesting thing is that fluids tend to accumulate in the Morrison's pouch on the right side, but can basically go anywhere around the spleen on the left side. So you don't want to only look at the interface. It can also go subphrenic here. And again, as a bonus, you get your left pleural effusion here. So once again, it's very important to recognize the kidney structure separated from the splenic structure that you recognize here, and here's the free fluid. So it's always easy if those markers are in there, but in real life you have to invent them yourself. Okay. So then moving to the fourth position of the FAST protocol, which is to look for free fluids in the ductless space. Of course, this imaging is different for it differs between males and females, because you will find the uterus here in females. So this is a coronal section, so it's rounder, and the urinary bladder has approximately the same shape in the sagittal plane, but the uterus is of course different. And you're looking for free fluid here, which is not here. So this is a negative FAST. Okay. This is a positive FAST, because you will get the fluids right here, and also here. Okay. So when you combine all these images, this is a case from our hospital with a rebleed after abdominal surgery. You can, if the fluid masses get large enough, you'll tend to see it everywhere. So you basically don't need to follow any protocol anymore. So the idea of the FAST protocol is that you see it in an early stage. So that's why you are looking at those specific points. Okay, so of course, as an intensivist, you have to always know your limitations. So the idea is that you only use it to make a binary diagnosis: fluids, yes or no. So you don't really want to attempt to quantify the amount of fluids, and you don't want to really make any assumptions or claims on what the content of that fluid is, whether it is blood or not, or whether it's a perforated viscous, because you are going to make mistakes. Okay, so FAST is of course part of the decision tree in the ATLS protocol. Basically, when you have a positive FAST and you're stable, you proceed to CT scanning still. If you're not stable, you want to do laparotomy. And if you have a negative FAST, you should repeat it after some time to see if it stays that way. So extended FAST is probably the response of the American surgeons to the lung ultrasound revolution initiated by Daniel Lichtenstein. So they wanted to make it extra fancy, and then they call it e-FAST. It just basically means to do your FAST and you have your lung ultrasound. So a very fast protocol to exclude pneumothorax basically in this trauma setting. But you've already heard a lot about this, so I will not repeat that here. Having said that, I have a few slides anyway. So you recognize the barcode sign here, and you would probably not have guessed this from this plain chest X-ray that there is actually significant pneumothorax in this patient. But e-FAST would have helped you tremendously here. Okay, so what else can you do with abdominal ultrasound? You can actually do a lot, and it's actually good fun to, while you're at it and making your intensive care ultrasound of heart and lungs, you want to get familiar with the surroundings of the abdomen, just in case sometimes you may need it. And it's also good to better understand your radiologist. But of course you should try and be a bit humble about your conclusions at first. So please discuss these things a lot with your colleagues and also your friends from the radiology department. But I'll just show you some examples. So a very interesting thing for intensivists is to do diaphragm ultrasounds. It's gaining popularity to, for example, to predict weaning failure or success, or synchronize ventilator settings. So basically you use the liver as a echographic window, and you'll recognize the diaphragm here as the bright white line. If you put an ammo through it, you can quantify its movement, and you can also quantify its thickness. So it's probably a useful asset for our profession. Okay, so let's say you're going to want to drain some ascites, for example, in a cirrhotic patient. You can of course use it to see where you do not want to put your needle. So you want to visualize the epigastric arteries and veins. So that's probably also a very useful thing, not maybe really abdominal ultrasound. So then the gallbladders, probably a bit hard to visualize after lunch in our test subjects, but maybe it's there. It's usually a black hypoechoic structure, and if there are stones in it, you may see a shadow artifact. And you can also measure the thickness of the gallbladder wall. Ideally, it should be 3 millimeters or less. Just the same, I hope you recognize now the liver here and the gallbladder, again, a gallbladder stone and a shadow from that stone. Sometimes you can also see sludge in the gallbladder. And this gallbladder wall can actually become really thick if it's inflamed. So it's sometimes useful to, for example, diagnose causes of fever in your intensive care patient, for example, the acalculous cholecystitis, or just the intervenable cholecystitis. So another interesting thing is to see the Foley catheter, the urinary catheter. It looks like a hypoechoic round structure. Here it's obviously good, and it's also useful to locate the bladder if it's empty as a reference point for one of your fast points. And you can also see that this Foley catheter is there, but it's not functioning because the bladder is still visible here. Okay. So moving on to the kidney. This kidney may be a little hard to recognize at first, but it's here, and the reason is that there is a hydronephrosis. It's still in the beginning stages, but here it's bigger. So here's the renal cortex, and you see the calyces have almost kind of disappeared in this fluid collection here in the pelvis. Okay. Of course, you can also measure the kidneys to assess their size. Normal kidney size, 12, 13 centimeters about. And you can also visualize the abdominal vessels. This is sometimes hard to do because, of course, there is a lot of gas in the abdomen. But when you try and push that away gently, you may get nice images, for example, of the aorta and the celiac trunk. Here you can actually see the subdivisions to the hepatic artery, splenic artery, see the caval vein, and you should recognize the shadow of the spine, because if you can recognize that, you can always relate the aorta to that, because it's in close proximity as a protection mechanism. So again, at a different level, the aorta with subdivisions, and please again remember this spine shadow, because it's a very important reference point. So if you recognize the aorta, you can also recognize when the aorta is too large, and probably here's an impending rupture with also a mural hematoma. And if you want to go really advanced, you can also do a Doppler for the hepatic arteries and veins to see if the common bile ducts, well, to see if it's there, because you can easily differentiate it using Doppler from the artery and the veins, and here it's also enlarged. And finally, just like lung ultrasound, you could also diagnose free air, because it will, of course, give a similar artifact as the lung. Here you see another example of this. finally, the final example of free fluids, and I would really like to leave it at that because it's a fast protocol, so it's a fast lecture and leaves us more time for scanning. Thank you.